So as you know, I'm going to talk about the European experience with private health insurance today. European health systems rely very heavily on public financing to cover the whole population usually, but they all allow some people to buy private health insurance, what I'm going to call voluntary health insurance or VHI, in addition to their public entitlements. If people are publicly covered, compulsorily covered by the government, but some people can buy voluntary health insurance on top if they want to. And one of the key lessons from the European experience is that voluntary health insurance is not an easy ride. It's really hard work for government. And I want to illustrate this today using two examples from France and Ireland. So this chart shows you how public spending on health dominates in all of the countries of the European Union, and that's the green bit of this chart. So public spending on health is really the dominant source of funding, but it doesn't account for more than 85% of total spending on health in any of the countries in the EU. And this leaves a gap in coverage, in publicly financed coverage. And in many countries, in all countries, this means that there are out-of-pocket payments for healthcare, which is the red bit of each of the charts. And then there is also a role for voluntary health insurance spending. And you can see that's the yellow bit of these charts, that spending through voluntary health insurance is really small in most European countries. So public spending dominates, there are out-of-pocket payments, and then there's a small role for voluntary health insurance. And if we think of out-of-pocket payments, the red bit of this chart, as being the gaps in coverage, you can also see that in most countries, voluntary health insurance does not really do a good job of filling these gaps in publicly financed coverage. So it's not always effective. Voluntary health insurance plays really different roles in different countries. And this is because it responds to differences in gaps in publicly financed coverage. I learned yesterday that it's very important not to use labels to talk about this, so I will just describe the different roles that it can play. In most countries, the most common form of voluntary health insurance offers people more choice of provider and faster access to treatment, particularly where there are long waiting times for publicly financed health services. This is the most common form. These types of markets are usually small. You can see on this side here. But there's one large market that is really outstanding or exceptional, an outlier, and that's Ireland. And I'll talk about that in a bit. Voluntary health insurance can also cover user fees, cost sharing, co-payments, co-insurance, deductibles, and so on. And this is the role that it plays in France. Alternatively, it can cover services that are excluded from the publicly financed benefits package. Most countries have some kind of very small market for this type of voluntary health insurance, but it tends to cover things like dental care or physiotherapy. And one of the lessons from Europe is that countries find voluntary health insurance to be a very challenging policy instrument. And there are two main reasons for this. One is that where you have voluntary health insurance, it systematically favors better off people, richer people, more educated people, people living in cities who have access to private providers. And because of this, it tends to exacerbate inequalities in access to health services. But it can also undermine publicly financed coverage in other ways. And it does this where it's large by drawing public resources, not just financial resources, but sometimes human resources too, staff people, drawing those resources away from need. So skewing the allocation of public resources away from need for healthcare. And I want to illustrate how this might happen using the examples of France and Ireland. So France first. France is really unusual in having a relatively high level of public spending on health, but explicitly deciding to limit that public spending and allowing people to filling the gap through co-payments, through user charges, but at the same time encouraging people to buy private insurance, voluntary health insurance, to cover their co-payments. It's unusual because it's achieved really high take-up of voluntary health insurance. Around 90%, 95% of the population has additional voluntary health insurance to cover their co-payments on top of their publicly financed entitlement. And the high take-up reflects a number of factors. First of all, really heavy co-payments in the form of co-insurance. So co-insurance across the board for all health services, including inpatient care. So there's a push factor. People feel there's a risk for them, a financial risk, and they really need to have the voluntary health insurance in addition. It's partly also habit. The voluntary health insurance market is really long established in France. It goes back for decades. And about half of the people with voluntary health insurance have it through their employment. But it also reflects really hard work on the part of the government through regulating the market, providing very poor households with free access to voluntary health insurance. About 5% of the population has free access to private health insurance, and heavily subsidizing voluntary health insurance for people who are poor. So free for the very poor, subsidized for the poor. In 2016, the government also made it mandatory for employers to partially finance voluntary health insurance for their employees. So really extensive intervention by the government in this market explains why it's so high in terms of take-up. But problems persist. There are still inequalities in access to health services between those who have bought their own voluntary health insurance, those who have free health insurance, and those who still don't have health insurance at all. Inequalities in the use of health services. And it's also very regressive and unequitable in terms of financing healthcare. And that's what this chart is showing you, that although out-of-pocket payments are now in France relatively evenly distributed across households, the burden of paying for voluntary health insurance premiums is really unequally distributed, and a much higher financial burden for the poor than for the richest in society. So a few lessons from the French experience. First of all, it shows very clearly that the poorest people, the most vulnerable people, are the most difficult to reach with any kind of health insurance coverage. And even though France makes all this effort and it exclusively targets its tax subsidies towards the poorest households, this hasn't been enough. And partly that's because people have to apply for this benefit. If you want to get the free voluntary health insurance or the subsidized voluntary health insurance, you have to fill in forms, and there's a bureaucratic process. And this clearly is an obstacle to access for some people. So the second lesson is that where you have entitlements, where you try and protect people, where you extend coverage, it's really important for this entitlement to be automatic. And that goes not just for voluntary health insurance, but for publicly financed systems too. And then the third and the most important lesson is that it's probably best to avoid making healthcare unaffordable through user fees in the first place. So when you're thinking about the design of your single payer system here, either go for no co-payments at all, or think very carefully about how you might design co-payments in a way that is not going to pose a financial burden for poor people, or for anybody, in fact. Ireland has a very different type of voluntary health insurance market. It covers around half of the population, and people buy it to have more choice of provider, access to private hospitals, and also faster treatment, to be able to jump waiting times in the public sector. But the result of this is that really, because the market is so large, covering 50% of the population, it really skews public resources away from need. So initially, the richer people in Ireland were not entitled to full coverage of inpatient care. So they had to buy voluntary health insurance to cover their inpatient care costs. Because of this, because the government wasn't paying so much for them, it felt it was reasonable to offer tax subsidies to these people to encourage them to take up voluntary health insurance. But the government also decided that voluntary health insurance financed patients could be treated in public hospitals through public specialist physicians, but that it wouldn't charge voluntary health insurance companies the full economic cost of using those public beds. It also said that physicians working in public hospitals could charge higher fees to privately insured patients, creating a clear incentive for doctors to prioritize these patients. And not surprisingly, a demand for voluntary health insurance financed treatment in public hospitals grew, and as a result, waiting times in public hospitals also expanded. At this point, people who are not rich suddenly think, help, I need to buy voluntary health insurance too in order to have faster access to treatment. I don't want to be stuck with a long waiting time. So the non-rich also start to buy private health insurance, exacerbating the problem of long waits in public hospitals. Then the government decides there is such a problem with waiting times in the public system that it's actually going to buy treatment from private hospitals, so public money being used to finance private care for publicly financed patients. And then to top it all, the government decides that if you're not young when you buy voluntary health insurance, you're going to be penalized. It creates a very strong financial incentive for more people, particularly young people, to take up voluntary health insurance. And so the vicious circle continues. Now, on the face of it, the government policy in Ireland seems really nonsensical. It seems that the public policy was weak. Indiscriminate tax subsidies benefiting richer people much more than poorer people, failing to have very clear boundaries between public and private provision. But I think it also illustrates how difficult it was for the government to act in a rational manner when faced with a combination of very powerful interests. And it wasn't just the private insurance companies that had a stake in this, but the richer people who were benefiting from having voluntary health insurance, and the providers who also benefited a lot from this system. So the interests were very difficult for the government to work against. Now the government of Ireland is reforming this system. They have finally realized that this kind of market has really detrimental effects when it is large, and they're going for something that is small. Small is beautiful, or at least less ugly than the current system. So my concluding slide, I finish where I began by saying that voluntary health insurance is really hard work for government. Countries in Europe encourage voluntary health insurance in some cases because it can relieve fiscal pressure for governments. But it also comes with costs, and I think that's very clear from these two examples here. That said, many of the challenges associated with voluntary health insurance can be anticipated. They're predictable. You can see them coming. Economic theory tells us that in a voluntary market, insurers are going to behave in a risk-averse way, and that means that there will be problems of access and affordability for voluntary health insurance. We've also seen from international experience that public policy is often weak and doesn't direct and regulate the market in the way that it should. Poor design, failure to monitor the market, failure to manage interests, and all of these have an impact. But the context also really matters. And I think that for many of the European markets, voluntary health insurance was established at a time when health insurance generally was much less established. What I understand today in the context of the United States is that you have a very mature, very sophisticated health insurance market. And I think that the implication for the US of that fact is that these challenges in the US are going to be even greater than they are in many European countries, and that the work for government is going to be even harder. Thank you.
Now we're going to move to Danielle. Thank you, Danielle. Thank you, Sarah.
Well, thanks so much. Thank you, Jim, for inviting me to join all of you today. I will begin with the same caveat I always start with whenever I'm presenting in the US, which is that I am not here to be an apologist for the many challenges and weaknesses and warts of the Canadian healthcare system, nor to proselytize its perfection to any of you. I am only here to give you some perspective about where I think there might be lessons that you could draw in your own efforts to improve healthcare here, where we call south of the border. And I'll bring my perspective as a practicing clinician and as a hospital administrator, as well as an academic. So I'm really just going to try to answer the question that I was asked, which is, how does private health insurance, or voluntary health insurance, as my colleagues call it, how does it work in Canada, and what are the lessons for you here in the United States? So this table is drawn from a special issue of The Lancet that came out in 2018 about the Canadian healthcare system. And I'm going to walk you through it because it really tells you all you need to know. In Canada, we have coverage that is very well known internationally for being what we call narrow but deep. And you will see in what I call here layer 1 that for medically necessary hospital and physician services in the Canadian healthcare systems, and our systems are run at the provincial and territorial, or the equivalent of your state level in our country, we have effectively a single payer, single tier system for which there is only public insurance. It is not possible to purchase private insurance. It is not possible to pay out of pocket to get faster access to services that are covered in layer 1, which means anything medically necessary provided by a doctor or in a hospital, period. But that doesn't mean that we don't have private health insurance in Canada, because layers 2 and 3 have lots of private payment and voluntary insurance involved. In layer 2, there is a mix of public and private funding, and layer 2 will look quite familiar to you, or it should, because it functions a lot in the same ways that your healthcare systems here in the United States function. We have some public coverage. Some public coverage, for example, for seniors. Some public coverage, for example, for people who are living in poverty or have disabilities. For people who are employed, there is private coverage, and many people are still paying out of pocket. And the biggest areas where this is relevant, and you heard Adam Gaffney speak about this briefly in his talk, is with respect to prescription drugs, dental, long-term care, and mental health care when not provided by a physician. Remember, I said doctor and hospital services are covered in the public plans, but if you're seeing a psychologist for cognitive behavioral therapy or a social worker or what have you, then those services fall into layer 2, and you will either be having public coverage because you fall into one of those vulnerable groups, or you have coverage through your employer, or you may have no coverage and be paying out of pocket. And then the final layer of services, layer 3, are those where people are mostly paying out of pocket or through private insurance that they purchase for themselves, or more often through their employers. And that's for things like dental, vision, etc. So does Canada have Medicare for all? Yes, absolutely we do, of the kind that you've heard described and aspired to throughout the day today, but we have it for doctors and hospitals. It is a 1960s designed system that has not evolved to represent the comprehensive health needs of our population. And those of us who are continuing to push for improvements and reform in Canada are looking to see how much can we push up services that are falling into layers 2 and 3 into that Medicare for all layer at the top. So how does private health insurance or voluntary health insurance work in Canada? Well, 70% of our spending, of every health dollar that's spent in Canada, is spent publicly, and 30 cents is spent privately. But as I've just described, in contrast to most of the other European and OECD nations that we've been talking about today, in Canada, that 70% is heavily focused on physicians and hospitals. So we have no co-payments, we have no deductibles, we have no co-insurance of any kind for those services, a heavy concentration in those doctor and hospital realms to the exclusion, and that 30% gets pushed out primarily into private insurance and private pay for things like prescription medications, etc. Which, with the result that 2/3 of Canadians actually do have voluntary health insurance. But again, that health insurance only covers those things that are not covered by what we call Medicare in Canada. And most of that private payment is through private insurance that's provided by employers in organizations. So as in every system, when you introduce voluntary or private health insurance, some people get left out. These graphics speak to who those people are. And in Ontario, my province, with the largest proportion of the population in the country, we currently have 1.5 million working people who do not have any coverage for prescription medications outside of hospital. Remember, we said if you're admitted to the hospital, you never see a bill, you can have an MRI, you can have an operation, you can have an ICU stay, you can have, IV amphotericin and anything that you could need, and every pill that you could possibly require will be given to you free of charge, and you will not see a bill. But when you come to see me in my office as a family doctor, and I see you and I diagnose you and I send you for an x-ray or an ultrasound or a surgical consultation, all of that is covered. And then I hand you a prescription and you walk out onto the sidewalk and you are on your own. And that has a very important impact on the health of Canadians and has led to the data that you've already seen regarding high rates of cost-related non-adherence to prescription medicines in Canada. And of course, a differential impact on women, on young workers, and on racialized workers, or what you call people of color here. So how does it work and how do we regulate it? And this is an old chart that has since had a few updates to it, but the fundamental realities of this chart remain the same. Is private insurance illegal in those areas where we have public insurance in Canada? In most parts of the country, it's actually not. There's just no market for it. And the reason that there is no market for it is because we do not allow doctors to bill patients more than the public plan would reimburse them for those publicly insured services. And we do not allow doctors to bill both publicly and privately. In other words, and I think this is a very important thing to try to communicate to an audience in a country where, as I mentioned to some colleagues yesterday, you see everything through the lens of insurance. Everything is about insurance in the American healthcare reform conversation, but actually there are many very important public policy and regulatory protections of a publicly funded healthcare system that have nothing to do with insurance at all. They have to do with how you regulate what physicians in particular can and cannot do and can and cannot bill for, and at what rates. And so as you can see, if you look across this chart, which looks at all 10 Canadian provinces, our 3 territories are not included in this particular graphic, you can see that there are bans on private insurance in some Canadian jurisdictions, but not all. And yet there is no market for private insurance because we make it sufficiently unattractive by regulating the price that can be charged. And therefore, we limit the market for it. So, what's the outcome? Well, we heard a comment earlier today about wait times for elective care in Canada. I always preface any conversation about wait times in Canada by respectfully reminding you that outcomes of care in Canada across a very wide range of acute and chronic diagnoses are as good or better in Canada as they are in the US on a population level. And so overall, when Canadians get sick, they get very well taken care of in our system. However, we have a very significant problem with wait times for elective care in some jurisdictions and for some issues, none of which, in my opinion, has anything to do with how much we spend or how we spend it, all of which has to do with the way that we organize our system. But that has given rise to a court challenge, a constitutional challenge that's currently in the courts in British Columbia, in which some American colleagues who are in this room today have participated in as experts. And the essence of this challenge is a challenge on the fundamental tenets of the public system in Canada, such that if the plaintiffs who are nominally patients, but actually is this surgeon, an orthopedic surgeon in British Columbia, Dr. Brian Day, who's trying to overturn the protections on the basis that he believes our healthcare provisions to be non-constitutional. This would overturn not just the ban on private insurance. It would overturn the ban on private duplicative insurance, but it would also, very importantly, overturn the ban on what we call extra billing, the ban on user fees, and the ban on dual practice. So I just want to say a couple of things about that. If you come to see a physician in Canada for a medically necessary service, it is not legal, and that physician sends a bill to the public insurance plan. And let's say the public insurance plan reimburses that person $50 for their service, but they feel they're a really great doctor, and their service is really worth $75. It is not permissible for that person to bill the public plan the $50 and then bill you the additional $25. The fee is $50. It's negotiated between the medical association and the government. It's set at a level that is believed to be fair in a transparent collective bargaining process, and that's the fee. Well, what is the incentive then for a physician to opt out of the plan and bill you directly for the service if they're not going to make a penny more? You know who pays on time every month? The government insurance plan. The patient not perhaps quite as reliable, and therefore there's very little incentive for a physician to bill the patient directly. The second thing is, should the physician wish to opt out of the plan and bill the patient directly, knowing they will only get $50 for that service still, but feeling on point of principle that the patient should pay and the patient will then be reimbursed by the public insurance plan, then the physician must opt out entirely and cannot participate in the public plan at all. And again, therefore, making it very unattractive for people who want to have a direct line to a solid, reliable source of wages, very, very unattractive for physicians to opt out. And so the number of opted out physicians in Canada is very small, not because private insurance is illegal, but because there's no more money to be made in the private sector than in the public sector. So in closing, then, I have 3 observations to share with you, one from each layer. The first I've just outlined. One of the important lessons from Canada for you to consider with respect to private health insurance is that prohibitions on private health insurance are not the only way to limit its use. They may be an important way in your context, particularly given the transition that you may face in a Medicare for All universe, but rules governing extra billing, dual practice, and self-referral are at least as important, at least they are in our context, to think about. Let's talk a little bit about considerations from layer 2. This is the layer in which, for example, for prescription medications, some people have public coverage and some people have private coverage. And you've just heard very eloquently from Sarah Thomson about how much this can be a real problem. Even when you ban or don't, create disincentives for private health insurance in the core, there will always be things that are covered by private health insurance, presumably on the periphery. And even that form of insurance can create problems. We see in our context, of course, much higher rates of administrative overhead in private insurance plans, and the transfers of so-called bad risks, meaning sick people, from the private sector into the public sector, because when they get sick, they fall back, and you know this phenomenon very well, they fall back into the safety net, and so you end up with the the healthier and wealthier patients in the private sector, and the unhealthy and the unwealthy in the public sector, and all of the inequities that follow. And then the final consideration from layer 3, where almost all of our where almost all services are privately funded. These are things that, as Sarah said, may not be avoidable, but are certainly predictable, is to think a little bit about what happens at the interface. So we now have, for example, in a few large Canadian cities, a flourishing of boutique medicine practices in which people can come for so-called wellness visits, and perfectly healthy individuals get subjected to a battery of stress tests and ultrasounds and mammograms at the age of 35, and heaven knows what else, and all kinds of things which are not covered by the public plan, and therefore fair game for somebody to pay out of pocket for. And yet we know that this is bad medicine. It is not just low value care, it's potentially harmful to the individuals who are getting it. And all of these tests then create referrals back into the public system for the incidental findings that result. And so you will never have a private pay section of the health system that is totally walled off. It's always a semi-permeable membrane in which people and problems and costs will, transfer back and forth. And thinking about what regulatory interventions are possible, not only at the level of government, but at the level of physician and other clinical regulatory bodies, and best practice guidelines, et cetera, is incredibly important as you think about how to navigate those intersections. Thank you.
Can you see my screen? Okay, so thank you so much, Steph. Thank you, Jim, for the invitation. Really disappointed not being able to be there in person with you today. Yeah, just to add insult to injury, my visa got ready this afternoon, but at least they gave me a 5-year visa. So I hope that next time I'll be able to join in person. My name is Frederico Guanais. I am Deputy Head of the Health Division here at the OECD. And it's my pleasure to share with you a few experiences and a few ideas about private health insurance in OECD countries. All right. So I think before in the beginning, it's important to set out a little bit of the terms and the context. In the OECD countries, we do have some variation in the model, in the main source of basic health coverage. So, of course, when you're thinking about the context of the United States, it's very common for you all to think about the insurance model, but that's not the case in every OECD countries. So we have first a first group of countries in which the main source of basic healthcare coverage is a residence-based health system. So that is just by being a resident, a citizen, or a resident, or a legal resident of the country, you are entitled to healthcare coverage. So that's all of the countries, for example, that have NHS type systems, national health systems, UK, Australia, Canada, Spain, Portugal, Sweden, and many other countries as well. So, and then we have a second block of countries that we have what we call the health insurance system. And then within these layers, we have a few countries that have effectively really a hardcore single payer. That's the first block of countries that we have there. Then you have another layer of countries that have multiple insurers with automatic affiliation. And then you have other countries in which you have multiple insurers with a choice of insurer. And these are the countries that are shown here: Chile, Czech Republic, Germany, Israel, the Netherlands, Slovak Republic, Switzerland, and the United States. However, there is something very different that really marks the American exceptionalism in this group, is that when we're talking about the Netherlands, Germany, Israel, you might have multiple insurers, but basically the insurance plan, the benefits that are covered are basically the same and are mandated for all insurance. It's not possible to price discriminate. It's not possible to deny coverage. So it's fundamentally different. And I think even though we consider those to be not single payer, but I understand when in the context of the United States, it's going to be much closer to what a single payer might be. So, and here's something that you already know, and you've been talking a lot. In 2/3 of OECD countries, all of the population has basic health coverage, which is often public. So, and here I think it's something that's very important, because if you look at the right side of this graph, you see where there's from Spain all the way to Australia, all of these countries have 100% of coverage of the population. So those are basically all of the high-income OECD countries. And United States here is in the left side of the graph, in the neighborhood of other middle-income OECD countries, such as Mexico, Chile, or countries that are even in the accession process to the OECD, such as Costa Rica and Colombia. So the United States at 91% of the coverage of the population is really something that the United States is away from its peers, in the sense that it is the only country that does not cover 100% of its population amongst all of the high income countries. So this is definitely something that gives us food for thought, and of course that motivates the whole discussion that you're having now. So here, I think it's important to point out that even in the countries that have 100% coverage and 100% public coverage, there is a market for the private health insurance, which is often voluntary. And I think this is something that's already been extensively discussed previously by what Sarah mentioned and so on. But I'd like to call your attention to one point. There are some countries in which the private insurance may serve as the primary source of insurance. Of course, there's the case of the United States under the mandate of the Affordable Care Act, which it's been questioned. So you could consider this as people who were covered within sort of a mandatory public option of coverage. In the case of Germany and Chile, there is 10 to 20% of the population who opt out of the public system altogether, and they're covered by the private insurance. So those are what we call the primary private health insurance. It's not really what you call the voluntary, but those people would be covered, they're mandated to have a health insurance, but they opt out to not contribute to the public system, and then they go to a separate private system. And then you have the voluntary private insurance that Sarah was mentioning, which I'm not going to go into even the explanation or the terminology, because unfortunately we use different names to each category. But in these countries, people may opt to purchase additional cover for a number of reasons, which Sarah already explained. So in here, I think it's what I'd like to point out is that this voluntary private insurance may cover up to 95% of the population in OECD countries. You see the case of France, for example, that has 96% of the population that purchases additional private coverage, typically for typically for the issues of covering additional co-payments. I'm starting to have a panic here because my computer is about to restart, so I hope it allows me to go through the presentation, but let's see how it works. And so coming back to the point that I was saying, so in many OECD countries, a large percentage of the population have voluntary private insurance. However, this is really a small fraction of the expenses, the health expenditures. So if you see here, I mean, there's a band here that you see where this is the voluntary health insurance. What I'm trying to point out here to you is that in most OECD countries, the percentage of the health expenditures that are covered by this voluntary expenditure is very small. And in fact, the universal of compulsory schemes, they cover between 50 and 85% of health expenditures. So I think this is important to point out that the majority of the coverage comes from the universal and compulsory schemes. So something that Joe mentioned earlier, the voluntary will not get you there. So, and I think at another point, it's important to highlight is that what is covered by this voluntary private insurance or on the out-of-pocket private insurance. And I think this has important implications to the design of the public system of the Medicare for all, if you will, that you're planning. So across the OECD, we see for all services, 27% of them are financed either by private out-of-pocket expenditures or by voluntary expenditures. So this unfortunately does not show the United States, but it shows that about a quarter of all services are covered across the OECD by this residual that's not covered by the public options. But if you look carefully, where is this mostly concentrated? This is mostly concentrated in dental care, because typically, as it was the case of Canada, there's very often it's not covered in the public systems. In some cases, 100% of the dental care is actually covered either by out-of-pocket or by voluntary contributions, and pharmaceuticals. So pharmaceuticals is also an area in which a lot of the expenditures across the OECD are financed by either out-of-pocket or voluntary insurance. So I think this is an important point, because if you do not cover these areas, there are going to be a market for these, or either people are going to pay for out-of-pocket or are going to have to buy a voluntary health insurance if it's allowed. So coming to the next slide, I think it's important to show that there are advantages and disadvantages of the different models. So if we take the case of Germany, in which people may opt out of the public system and go to a private system, so it happens that typically the people who do this are the ones who are better off. So the people who are healthier, wealthier, younger, because these are the people that the private markets will offer a lower rate and will try to lure them into coming to this alternate system. So there is a proven adverse selection that the healthier private policyholders, they opt out of the public system and they reduce the pooling that's available for the public option. And there are waiting times that are shorter for the patients with private insurance because then there's the competition for limited resources within the health system. So that shows the kind of problems that may happen. It's important to point out that in Germany, this may only happen until you're 55. After you're 55, you can never go back to the public system. So it happens that healthier people who suffer a health shock when they're young, they go back into the public system, but that may not happen if they are older. In terms of the duplicate health insurance, those are the ones in the residence-based system. I mean, so people would purchase additional insurance, which is the case of Ireland, which is the case of UK and Australia. So the evidence shows that this may limit the access to healthcare services that are available to the patients with public insurance, and again, because of an issue of competition for resources. So in the UK, we see evidence that in areas in which there is more higher waiting times, people tend to buy more private insurance. We don't know whether there's a causality, but there is a correlation. But then again, as Sarah and as Danielle pointed out, there might be problems also in effects in the duplicate cause on the public system. Now, going to the supplementary private insurance. I'm trying to avoid the label, sorry. So the supplementary private insurance is the insurance that you purchase to cover uncovered services. Sarah has a different terminology for that. So because we're talking here about different basket of goods, in this case, there would be no perverse effects on the system a priori, right? So you're buying additional coverage for things that are not covered on the public system. However, this actually shows that because there's no vertical redistribution and the possibility of risk selection, this can also influence the public markets as well. And in here, there is very, very aggressive cream skimming. And we see, for example, in the cases of Switzerland and the Netherlands, that very often the same insurers who are non-profit in the mandatory statutory markets, they are for-profit in this additional supplementary private insurance where they go full-blown cream skimming, good risk selecting, and so on. And finally, for the type of insurance that covers co-payments, I mean, which is the case of France that Sarah was mentioning. It might help to control the growth of public spending, but this is at the cost of an increase in the amount of residuals that are covered by private insurance. So you're actually shifting further and further areas that will have to be covered by the private insurance. And in here, there are all the equity problems that Sarah mentioned before. So coming to my final thoughts, I think that why are we talking about private health insurance if the discussions about Medicaid, Medicare for all, I'm sorry. So I think it's important to realize that the design of the public insurance will matter. So what's covered in public insurance will matter. And as much as we would like to cover everything in the public insurance, different difficult choices are going to be have to be made. And this will affect on whether there's a need for this additional private or voluntary market. So across the OECD countries, historically, the private insurance gradually evolved into a secondary role or a highly regulated role. So I think this is very important. Even when private insurance exists, as the case of Germany, for example, pure private for the 10% who opt out of the system, this is highly regulated. But on the other hand, the private insurance market never disappeared from the OECD countries. And every now and then when there's discussion about budgets, there's renewed attention to it because, well, we're going to spend more. There's predicted increase in demand. There's long-term care needs coming along the line. So there is a discussion that comes back and forth. And in there's a lot of discussion in terms of the political arbitrations between the desire to increase the pooling of risks outside of public budgets and to increase the financial sustainability of the healthcare supply. So many see this private health insurance market as a way to, well, let's take this away from out of pocket and let's pool risks, which would be a better option than just letting people go full-blown out of pocket. However, we do know that there is a strong impact on equity, as Sarah mentioned before, both from the funding and access perspectives, and also on the public care provision because of the competition for limited resources. So I hope this thoughts will contribute to the discussion and will bring the attention to the design issues that you're considering. Thank you very much.
If you can hear me, Frederico, oh, there we go. You're back. You've stopped share. Good. So the floor is open. We have time for a few questions before lunch, please.
So my name is Bill Bronson. I'm a physician. I'm sorry that I always have a question for something, but I'm loaded with issues. First of all, I just want to say in 50 years, the only time we've made great advances is when we've had a piece of legislation. When we talk to each other without a piece of legislation, it goes up in smoke. Everybody has an idea, everybody has an opinion. So we have 1384, and I don't know if you have read it carefully. It is an extraordinary piece of legislation, and that should be our starting point for all discussion. In America, when
So Bill,
we...
super
yes,
short.
I'm
We have
gonna
only a
get
couple
there.
minutes in for questions.
I'm going to get there. I promise I'm going to get there. When in America, we are not going to copy or have anything limited like there is anywhere else in the world because we have enough money and the politics to make that change. That's the base, okay? So here's my question. One of the choke points is the lack of adequate personnel. What kind of subsidies are being provided worldwide or whatever to double or triple the number of professionals we have, not just doctors, but all the intermediary staff and dentists? That's number one. Number two, I'm interested in the people owning the medical system. Up to now, the medical system is another land in our land. It is owned by them. Are there models or examples of where there are people, public, genuine ownership of the whole system so that it can't strike out when they are when the system is pressed for change? Do you understand that question?
Yep, very good.
Struck in Saskatchewan because they own the system. We don't own our medical care system. It's owned by the corporations. How do we make that shift?
Okay, what I'm going to do is to take two more questions and then have a quick round of responses because then we'll be out of time. As I said, I'm going to take 3 questions and then have some joint answers.
Hi, I'm Dr. Tanasevich. I'm a physician in Marin County, and I have a question specifically for...
That's fine. It's on. Just close to your mouth and speak up.
For Dr. Martin. In the U.S., the cost of medical education is prohibitive, and it makes a system that is very restrictive on compensation to physicians very difficult. Do you have the same issue with the high cost of medical care? Do you subsidize medical education to a greater degree than we do here in the U.S.?
Very good. Another question in the back there.
Hi, Miranda Dietz from the UC Berkeley Labor Center. In a country like Germany where there are different insurance providers, what's the role of those insurance providers? What do they do and what value are they bringing?
Okay, and I'll take one more right here. No, but we need a microphone, otherwise Frederico can't hear you. Okay.
I'm curious, is your recommendation no private insurance? Have you seen the detriment and sort of the erosion? You're saying it should all be public, or you think the regulation of private is enough?
Okay, very good. Frederico, I'm going to let all of you take a whack at it, but let me start with you just in case we have a technical problem and we can work on that when they're talking. So why don't you start?
Okay, yeah, that's wise. So about the question of ownership, I think probably the system that is closer to what the question refers is the NHS, is the British NHS, National Health System. It's so we're really and even in terms of you look at the pride the British people have in it. So I mean, I think Sarah should speak more to that than I do. But I would say that would probably be the closest thing to what your question, sir. In terms of, I'll also take a shot at the cost of medical education, which I think is a very relevant point, because this is also a point in the OECD countries. The cost of medical education is really neglectable compared to what it is in the United States, or it's free. So actually, you might go into medicine and do not have to pay for the cost of your medical education because it's public subsidized. And I think this is an important point that really should also be considered and should also be discussion in terms of the provision of the health workforce. In terms of what in Germany, what do they do? What the value that they add? So I think that in the German model, I would say that they are inspired by the things that are happening in the United States as well. I mean, some of the interesting developments, which there are positive experiences coming out from the United States in the area of affordable care, from the accountable care organizations and so on. But I would say that the market's more heavily regulated, so they add much fewer value because there's much less room for innovation. So I would be pressed to give you an answer to the question, which really what's the value that's being given by the private providers in Germany. But I'm not saying, I'm not recommending that there be no private insurance. What I'm saying basically is that in the markets in which there are private insurance, like in the Netherlands, in Switzerland, in Germany, in Israel, the role of the private insurers is heavily regulated. So that's absolutely something that I think that's the experience from the OECD countries, and that's something that should be considered for discussion in the United States. I'll stop here.
Yeah, there we are. Good. So since continuing in reverse order, Danielle, do you want to take the next shot?
Sure. So first on the cost of medical education. So the cost of a medical education or a health professional's education in general in Canada is high. It is not as high as it is in the US, but you know, I graduated from medical school in 2003 and I had a $180,000 Canadian debt. And that was, you know, a number of years ago. It is common for people to graduate medical school with debts of that at that level. And I will say that unlike many of the European countries that you've heard referenced today, physician incomes are also very high. In fact, I had a slide on comparative physician incomes in my presentation originally, and I took it out. I should have left it in. Canadian doctors make very good money. Again, not quite as much money as American doctors, although in some specialties we earn more. Most of those incomes are publicly disclosed. You can look them up. There's a thing called the Blue Book in British Columbia. There's a whole expose in the Toronto Star about Ontario physician incomes. All the data is fraught. It doesn't include overhead. It only includes billings, et cetera, et cetera. There's a million complaints about it, but it will give you a sense of what a Canadian doctor earns. And very often it is as much, and in some cases more, in some cases less than American physicians, because we are in a common market with you for our professionals. We cannot afford to pay our doctors half of what your doctors earn, or they would all come south of the border. One of the reasons that they don't do so, and they don't do so, is because they are very well paid in Canada. The second question is with respect to what do I think the role of private insurance should be. If you truly want an equitable healthcare system, you should not have private insurance that duplicates what is covered in your plan, period. No duplicative insurance, period. Should you allow private insurance, and as we've seen, you should not have co-payments and you should not have deductibles, so you should not need insurance to cover those things, so you shouldn't have them. I think, I mean, that is, you know, that is how you structure a just healthcare system. Should you have insurance that covers those things that are not covered by the public plan? Yes, of course you should, and you shouldn't cover everything for everyone all the time. you should cover things that have evidence that they actually improve health, which is the purpose of a healthcare system, which means you can't cover all of it. And so for those things that should not be covered on the basis of solid medical evidence, or because there is a limit to the public resource pool and not everything is cost effective, and you're going to have hard social conversations like the rest of us, welcome to the club, about what should be covered and what shouldn't, you're going to get into those difficult conversations, and you're going to need to have some ways for people to purchase those things that are not covered. And so when you do that, then pay attention to the interactions, is all I was trying to say, because nothing ever exists, completely separate from the public system. When you have a strong and big and vibrant public system, what you allow people to pay for privately at the margins will have unintended ripple effects back.
Thank you, Danielle. And to close us out, Sarah.
I'm just going to respond to the question about Germany. So the question was, do the health insurance funds in Germany add value? And I think we have to distinguish here between the public bit of the system and the private bit of the system. The publicly financed system is run by health insurance funds called sickness funds. And when these were established over 150, 200 years ago, they were formed at very local level, so really representing local interests. They had representatives on the board of patients, of government, local government, of employees and employers, because all of these stakeholders had some skin in the game. So they were really providing a very local function, and that's the function that they fulfill today. When it comes to the private health insurance system, I think it is more questionable about the value that they add there. And this combination of public and private health insurance in Germany is really detrimental to the overall performance of the health system, because it creates very blurred boundaries and inequalities in access. But the reason why Germany still has this dual system of public and private, and why it still has this system of multiple insurers, is because of history and path dependency and the difficulty of really shifting from having a radical shift from one system to another. I think the lesson for the US in that is, when you do manage to reform your system, make sure you get it right from the beginning, at least in terms of the fundamentals.